Welcome to the Home Health Skilled Nursing Competency Part 1 with Amity Healthcare Group. This specific section is going to focus on Oasis-E and case management concepts for RNs. So if you happen to be an LVN or an LPN, you are permitted to skip this portion if you like, just due to scope of practice. Quick mention that we are intending this presentation for educational purposes only, and it may not be modified or redistributed in part or in whole without permission from Amity Healthcare Group. And so let's dive right into the elements of an admission to home health. Pretty much every admission is going to require some type of that assessment is required to be completed by an RN, a PT, an OT, or a speech therapist. So depending on what therapies or services or combination are ordered will determine who's going in to complete that. Most of the time, if a skilled nursing service is ordered, the CMS recommendation is that the RN should be completing the admission assessment and the Oasis assessment, but always checking with your agency leadership and kind of what's going on. In terms of that, it is required that when your agency accepts an admission referral, that care is started and that admission assessment is completed within those first 48 hours. So kind of work with your team, but that's the general recommendation. It's very critical that we understand what our patient's insurance status is and what that requires and what our agency policies and procedures are so that we're completing the right assessments. So to simplify that, Medicaid and Medicare insurance carriers, those patients always have to have an Oasis assessment completed. That data has to be collected and processed accordingly, and so that's typically an easy one to kind of figure out. Sometimes the patient may have a private insurance that isn't Medicare or Medicaid. That insurance may still require that Oasis assessment. So it's important to check back with whoever is managing that and knows that information to help you to make sure you're doing the right thing. There are agencies that just collect the Oasis on everyone. So if that's your agency policy and procedure, then you definitely have to go with that. When we're talking about Medicare home health requirements, this is really specific to our Medicare population. Medicaid varies on what the state rules for your Medicaid patients are. So they may be different, and those patients may or may not be required to be homebound. Medicare plans do require for home health, skilled home health services, that patient be homebound. And this is something that the admitting clinician has to assess for, but then everyone after that at every visit needs to continue to make sure that that patient meets the homebound criteria and that is reflected in the record. And what that generally means is that it's a taxing effort for that patient to leave the home. They're not leaving the home for prolonged periods. They generally are not driving themselves, although driving is not a specific requirement in and of itself. We have to look for things like it's, short visits for specific reasons, episodes leaving the home, the patient requires assistive devices or the assistance of another person. And again, it's that taxing effort for infrequent periods. Most of that patient's time is homebound based upon the medical reasons that we're seeing them for home health care. The patient is required to be under the care of a physician or another allowed practitioner. So depending on your state and the scope of practice requirements, it could be a nurse practitioner or a PA, for example. But there is a face-to-face requirement linked to that. And so what that means is when a home health agency admits a patient, they need to have evidence that that provider or a provider saw the patient either within 90 days before the date of admission or within 30 days after that date of admission. Certified. Discussing emergency preparedness and evaluating the patient's risk level. This again is ongoing depending on the patient's needs, depending on if their status changes. But every agency is required to have a process at admission to determine what is the risk level, what are they assigned, and then what is their plan in the event of emergency. So make sure that you're clear on that process and that it's reflected where everyone can find it. The specific role of the RN in home health. Depending on agency process and structure, nurses, RN specifically, often serve as the case managers for their assigned patients. We oftentimes are the ones providing those skilled services specific to nursing in the home. Many times, though, the RN is sharing visits perhaps with LVNs or LPNs. So when you're not in there doing the visit yourself all of the time, that's really where that care coordination and that communication is even more important, making sure that you're aware because you're still responsible for overseeing that plan of care. And some other responsibilities of the RN in home health, or a huge responsibility, is likely going to be those comprehensive assessments, reassessments, anything having to do with Oasis. I often joke with LVNs and LPNs that, they're a little fortunate. They don't have to worry about those, but the RNs do. So a lot of it does fall into that. That plan of care oversight. So it's not in the scope of practice of an LVN or LPN to develop the plan of care and to make those changes, although they can provide the skilled care under that. They're, of course, the contributing team member like everyone else, but the RN, no matter how many visits they're doing or not doing, has to make sure that that plan of care is being followed and that it meets those patients' needs. Developing and managing the home health aide or the CNA plan of care. So in home health, as in many settings, aides, CNAs, they're allowed to provide care that must specifically match the plan of care that RN has written. And so it's also important to remember to check in. You're going to be required to do supervisory visits for CNAs as well as for LVNs and LPNs. But when the aides find that perhaps the plan doesn't match what the patient needs or wants, it's important that they know to communicate with you to update that. So for example, your plan of care is very specific that that patient is going to get a shower. All of a sudden, the patient prefers a bed bath. Well, the aide can't do that without checking with the RN and getting that plan of care updated. Things like that. So we have to make sure we're on that. Supervision, that is, again, specific to a lot of things, but LPNs and LVNs can't supervise aides and they can't supervise themselves. So the RN does have to oversee that care. And I always remind everybody, it doesn't mean that you're everybody's manager. It doesn't mean that you're, having to deal with them directly in that sense if that's not your role. What you're supervising is the care provided and if the patient's needs are being met and if they're satisfied with that. Anything beyond that, absolutely take it to your clinical manager or whoever that person of authority is. But you're really checking, typically with home health, if you have an aide or a CNA with other skilled services, those CNAs and home health aides need to be supervised at least once every 14 days and per agency policy. So if your agency policy is more frequently, then you've got to demonstrate that. And so you're just making sure that the patient is satisfied, that the aide is providing the care according to that plan of care, and that everything's going great. And if something needs to be adjusted, you adjust it. Of course, you can do that at any time. Now with LPNs and LVNs, that's going to depend on what your state requires, if there are requirements, or what your agency policy is. So for example, in my state of Colorado, there's not a hard set requirement by the state as to how frequently LPN and LVN supervision has to be. But most agencies have a policy of either once every 30 days or once every 60 days, depending. Okay, so just be clear on that to make sure. A lot of agencies get in trouble when there's not evidence, clear evidence of what's going on. And again, if it's outside of Medicare too, the rules can change. So making sure that we're clear on how often and how we're going to meet that need. Home health aide and CNA supervision, as I mentioned, every 14 days when skilled services are provided, and LPN and LVN based on agency policy and state requirements. Medication management, huge responsibility of the RN to make sure that that's always current. We mentioned how the patient has to have that current medication list at all times. Some things to remember with our plan of care development is to keep it nice and simple. So sometimes what happens is we start to develop a plan of care, we want to make everything better, we identify all of these needs, and we get a little bit carried away. And then what ends up happening is it doesn't look, based on our documentation, like we're actually meeting the goals and meeting the expectations of that plan of care. So we like to tell people to imagine your typical visit, have the plan of care reflect that visit, and then it's always going to be clear on paper that it is patient focused. So if the majority of the reason why you're in the home is wound care, even if the patient has a ton of other things going on, it's not that those things don't matter and we don't take them into account. You want to avoid listing a bunch of goals and interventions on the plan of care that you're not really going to be working on through your home health services. Another good idea is take a look at that plan of care. If you did your job really well and you know your patients, you should be able to kind of pick out which patient it is just by looking at the plan of care without looking at their name, because you know what the care is and how that visit's going to go. So just a little tip for success there. In terms of transfers and discharges, these are other times in the episodes when OASIS assessments are required. And discharge transfer documentation, oftentimes, again, this is under Medicare requirements, CMS requirements, Medicaid, depending on your payer source. You do need some discharge and transfer orders once you find out that the patient is being transferred or discharged. Many times there is an OASIS required for discharge as well as for transfer. If you're going to be discharging the patient, the notice of Medicare non-coverage is required to be provided to that patient 48 hours prior. So if it's a Medicare discharge, always ask yourself, make sure if that form needs to be delivered that it's done and it's signed, and you don't inadvertently discharge that patient without obtaining that. When there's a discharge for whatever reason, the agency is required, you're probably going to be required to author this, send a discharge summary to that healthcare professional who's overseeing the plan of care within 5 business days of the discharge. So that's the time frame that we have, and it basically indicates what happened during the episode of care, why the patient was discharged, regardless of the reason. Transfer, and the most common is the patient was transferred to a hospital, for example, or a skilled nursing facility, a higher level of care for whatever reason. That's required to be sent within 2 business days if we know it's going to happen, right? So within that planned transfer. But many times patients are transferred before we are notified, most common being for an emergency hospital visit, and they end up hospitalized. Of course, we want to try to avoid that when possible. But if it's an unplanned transfer and that patient was still on service with the agency, it's 2 business days within finding out. So if you go in that door, oh my goodness, Mrs. Jones was admitted to the hospital 3 days ago, we forgot to call you. You've got 2 days from finding out to get that transfer summary completed and sent to the provider. And the transfer can happen with or without discharge. So perhaps the patient is transferred, it's a brief hospital stay, there's still plenty of time left in the episode, they come back, we can do what's called a resumption of care. But if, let's say, they get transferred, we don't expect them to come back, or their episode ends, and they're still in the hospital, that's going to be a transfer with a discharge. So the ideal situation is that we have met all of the patient's goals, we did all this great job in the time that we had them, and then they were discharged, based on that situation. But sometimes a transfer or a discharge can occur if the patient asks for it. So you want to avoid this, of course, but perhaps they're not happy with the care that they're getting, and they ask to be transferred to a different agency. Or they ask to be discharged because they don't see a need for the care. They refuse the care, and that happens. Let's say there's a change in condition. That hospital transfer was a good example. Skilled nursing, they need a different level of care. Home health is no longer appropriate. Then that could result in a transfer and discharge. Death is usually not an anticipated outcome in home health, but it does happen. So if the patient happens to expire while they are on service, then that would be definitely a discharge. The documentation has to demonstrate that whatever the decision was for transfer or for discharge, that it was patient-focused, never for agency convenience. There are times when an agency has to discharge a patient for cause, sometimes due to things like safety for the staff, or the patient just not being, cooperative or appropriate. And agencies always have internal, policies and processes, as do states, to follow to make sure that everything is done appropriately. And that's kind of a whole separate conversation. So let's talk a little bit more about Oasis-E specifically, which, as we mentioned, is the current version. And just to review, Oasis assessments are completed. They're required at start of care and admission. Any transfer with or without a discharge, a resumption of care, the patient went somewhere else, different level of care, came back and were resumed, or a discharge for the reasons that we looked at. So Oasis is called, interchangeably a lot, comprehensive assessment, Oasis assessment. It really is a data collection tool, and it's important to remind ourselves of that. And it kind of keeps getting more and more interesting and complex for different reasons, which we'll touch upon. But there's a lot of reasons why Oasis exists as it does. And part of it is that it is a condition of participation. If your agency is receiving funds, is participating in any Medicare, Medicaid programs, they Got to do Oasis. There's no way around it. And it's really hard to work with any other insurances, right, if you're not Medicare and Medicaid certified. So that's just the way it goes. The Oasis tool is used for measuring quality of care and care processes. So there are lots of data that's collected on that. Some of that is even reflected in some of our satisfaction scores, which we'll talk about a little bit. There are links to episode payment and reimbursements, depending on how agencies scored on outcomes. We don't want to show that patients are getting worse, especially in certain areas under our care. We're held accountable for that. And the data is gathered from your, for example, Oasis admission versus your discharge Oasis. Did the patient improve or did the patient deteriorate under your care? And a lot of this is being pulled into the star ratings that you probably have heard about, right? If your agency is a 3, 4, or 5-star rated agency on Care Compare. So it's a business thing, patients and their families, it's public information as to how agencies are ranked. And so they can get on Care Compare website and try to decide which home health agency they want to go on based on your quote unquote report card. Parts of the tool are used to see if there are any patterns of fraud and abuse. That's always an ongoing thing. And now we've got this wonderful thing in home health called value-based purchasing. So depending on some of these outcomes that the Oasis and other measurements and tools are rating us against, it affects whether we receive more or less reimbursement. And this can definitely and directly impact your agency. Those quality measures can change compensation by as much as 5%. And some of you may know more about the business side of home health than others, but margins are pretty tight. It doesn't seem to be that home health agencies are granted a lot of leeway or raises or extra payment. And so that 5% makes an enormous difference. And so for your agency to thrive and for you to continue doing the work that you do, we all have accountability in that. Completing the Oasis assessment accurately is critical because of all of these reasons. If we're not being accurate and we're not being attentive to what's changing and all of that, and of course we're always being honest in that accuracy, we really can make the agency look like it's doing way worse on patient outcomes than it is. So we want to base our responses on the patient's baseline, what's going on with them at present within the last 24 hours. Don't forget to use the family and the caregivers as well as sources of information, and just do your absolute best, but do take it real seriously. Anytime you're asked about whether they need assistance, it's typically if they need assistance from another person, not from an assistive device. So that's kind of a rule of thumb. So this Oasis-E, which is different than the D, which was just before it, of course, that it does have some extra sections. So since it's been around for just over a year now, a lot of us are still kind of wrapping our brains around it, getting a little bit more comfortable with some of the newer aspects of it. So this slide just gives you kind of a little snapshot of some of the different sections and what is linked to each section. So I'm not going to read each and every one to you, but I'll give you a second just to kind of take a peek at it. And the more you work with it, the more it becomes familiar. But the questions will be, numerical, and then they're going to have the section number based on the letter of what the question relates to. And so some of the differences in Oasis-E compared to earlier versions of it is that there's a much heavier emphasis on what we call social determinants of health. But there are many questions now that are heavily linked to health outcomes, questions that are asked of the patient. And of course, the patient, it's totally voluntary for them to answer or not answer, but we're required to ask on ethnicity, race, culture, and their preferred language. And so we want to try to gather as much of that data as possible. Things about transportation, needs for daily living, health literacy also is now kind of new to Oasis-E. And so we want to actually ask them how often they need help to read instructions, pamphlets, and other written material from your doctor or pharmacy to kind of get a sense of that level of health literacy. Social isolation, which by the way has been declared a public health pandemic, is something that we want to assess for, and so we're going to follow the questions specific to that. People who are isolated, lonely, are shown by the data to have poor outcomes compared to people that have good social connection and support. And so that's an important part of the comprehensive assessment. So with the Oasis-E, we go into what's called the BIMS, which isn't something we did on previous versions of the Oasis to this degree, but it's the brief interview of mental status, And so that's going to be in your section C under the cognitive patterns. And so BIMS is going to be real specific in C0200 through 0500, and it's going to ask you to ask that patient to repeat 3 words. It's going to have temporal orientation assessment on the year, the month, the day. Can they recall the 3 words that you asked them to repeat? And then there's going to be some summarization of that. So you want to kind of look at this ahead of time if you're new to it. Make sure you're comfortable asking them and kind of know what to expect. If the patient is not able to complete the interview or this process, it's inappropriate, you're going to enter 99 for this. And then the rest of section C continues with questions specific to delirium, which is an acute mental status change, cognitive function, confusion, and anxiety, determining what are the potential causes and needs as a result of this. You want to allow time, privacy, dignity to do this. And again, considering that baseline status, right? What's this patient been like for the last 24 hours or so? And so kind of working with that to see, is this something that is permanent? Is it transient? Is this something I'm going to assess for right now? But BIMS is something that's a little bit new. Section D goes into mood, a little bit more in depth than previous Oasis in terms of, asking about depression and that kind of thing. The PHQ-2 is still part of the assessment. It's just kind of the exploratory piece. And then if the assessment reveals that there is a frequency and a score of 2 or 3 on the symptoms based on those first 2, then it's going to continue into the PHQ-9. So depending on that patient's status, you may be spending a little bit more time, and again, being sensitive to dignity, privacy, what's the baseline, what's the environment like, is this the right time to be asking those questions, those kinds of things. And if this is not something the patient is able to complete, then 99 is the answer. And there's that social isolation in D0700. How often do you feel lonely or isolated from those around you? And it's good to give them, time, maybe even, ask the question again, make sure they understand what you're asking, kind of asking who is their social support. There are patients who, we might think is lonely and isolated, and they feel okay with whatever their circle or not, an existence of a circle is. And some patients can actually feel lonely and isolated, even if there are a lot of people visibly around them. So just kind of keeping all of that in mind. Section J goes into health conditions. With value-based purchasing, 35% of the weight is based on hospitalizations and ER visits. And so what this means now for home health agencies, anytime a patient under the agency's care, anytime they have to utilize the hospital ER visits, it is counted against them in those measures. And so it doesn't mean that we're going to be able to avoid everything, but what it does mean is that we have to do our best to prevent that, right? What are we doing with education, with being ahead of what it is that they might need? Is it something that can be taken care of with a provider's visit or an urgent care visit, for example, which isn't billed and weighted the same as an ER visit? Are there resources in your community such as we have one here in the Denver area called Dispatch Health. It's kind of like urgent care coming to you, and it doesn't count as an ER visit. Do patients understand, right, what their options are, and can we help them, stay out of those acute care situations if that's appropriate, of course, right? And just doing all of that work. It's critical that clinicians accurately assess the risks, work with that team. If we know coming in that patient is a high hospitalization risk, what are we doing to avoid that? Are we seeing them more upfront? Do we need to ask for authorizations for more visits to accomplish that? Is there documentation of coordination to work on those things that make them high risk versus perhaps a patient who's lower risk, right? So just kind of working with that whole team, because that's often what it takes. Things such as pain, risk for falls, recent falls, right? History of falls, dyspnea. Those are some of the key ones that usually increase that risk exponentially. And it's really important that we get that accurate history so that we can rate that risk accordingly. Oasis is also going to ask us to look at our high-risk drug classes in section N0415. And this is something we do at start of care, resumption, and discharge. So if patients are taking any of these medication classes, or if they have an indicated need for it, these are considered high risk. And so we need to be sure that we are noting that we know that we're providing education on safety, on interactions, things like that, So your antipsychotics, anticoagulants, all of them, by the way. Antibiotics, especially if there's an active infection, because that's why they're on an antibiotic most of the time. Opioids, antiplatelets, hypoglycemics, and this does include your insulins, they are high risk, or none of the above. So you're going to be asked to assess to see if they're taking any medications in these classes. And we've gathered this mountain of information. What do we do with all of it? Well, ideally, we're looking and using it to identify risks and needs, and we're being proactive in getting in those resources. It's really a big picture view of how high risk is this patient? What does this patient need? And it does put a lot of onus and responsibility on the agency, because sometimes we're in there for something that isn't related to all that. But while we're there, we're still responsible for this. The BIMS tool provides useful information for possible dementia screening and diagnosis. So there's a big push to try to get that obviously sooner rather than later, again, linked to that risk and better outcomes. Are we utilizing referrals to MSW's community resources, kind of bringing in what that patient needs and doesn't even realize perhaps that they have access to, or helping them get access to that? Are we prioritizing care coordination to manage hospitalization and ER risks? That can't be underemphasized. We can't actually overdo that. And nowadays with the type of acuity we're seeing with patients across the board, it's not a bad idea to just assume they're all high risk for hospitalization and ER. What are we doing to help prevent that utilization? And using those updates to improve quality outcomes, because again, that's part of our report card, what we're being looked at for all kinds of reasons. And that concludes section 1 of our skilled nursing competency section. Thank you.